Morris was a clinical health officer. He was working in Calhoun Ebola Treatment Center. He, like many of the Sierra Leonean health workers, worked for months. Whereas I had the privilege, as with all international workers, I could come in and I could leave. If I got unwell, I could be evacuated. But Morris, like the other Sierra Leoneans, did not have any of those privileges. And yet he came to work every single day to provide healthcare to women, men, children with Ebola, and seeing every day death on a scale that none of us should ever be prepared to witness. And Morris, unfortunately, like so many healthcare workers in Sierra Leone and West Africa, himself was infected with Ebola, and he died in the same Ebola treatment center where he had spent the month before looking after and caring for others in the same situation. And I think that, the loss of Morris and the loss of all of our colleagues at that time will have repercussion for generations.
My name's Lindsey Hilsum. I'm the international editor of Channel 4 News, and I'm delighted to be interviewing the author of this book, Benjamin Black, which has won the C.G. Moore Prize for Human Rights Writing. And it's very unusual to win a Human Rights Prize because it's a book about health and medicine and things which often don't get included in the human rights discussion. So Ben, tell us a little bit, first of all, about who you are. You're an obstetrician and gynaecologist. You're from London. Tell us a bit more about yourself and how you got to Sierra Leone during the Ebola epidemic.
Sure. Thank you very much, Lindsey, for being here. It's a real pleasure, and it's a real honor to run this award. So as you said, I'm an obstetrician and gynecologist. I work part-time as a consultant in London, with a special interest on high-risk pregnancy and ensuring that there's access to safe abortion care to marginalized and difficult to reach populations. And I also work the rest of my time as a specialist advisor to humanitarian aid organizations, including Médecins Sans Frontières. My personal background is that I actually grew up in Manchester. I'm half Iranian, half Eastern European. And I think a lot of my sort of family heritage and family background is what took me towards a career in humanitarian aid and in health. And I suppose my journey that sort of got me to Sierra Leone was that journey in pursuing a career in humanitarian aid with a focus on health, which I think for many doctors, nurses, midwives would resonate. That naturally drew me to Médecins Sans Frontières. And actually, this was my first placement with the organization was in Sierra Leone. But it wasn't for Ebola. It was for pregnancy healthcare. At the time, it was 2014, Sierra Leone had been ranked by the World Health Organization as the country with the worst maternal health indicators and the highest risks for pregnant women and girls dying from pregnancy-related causes. And so that's why I was in Sierra Leone. Ebola was a surprise.
Let me interrupt you just there. So you go to Sierra Leone for Médecins Sans Frontières as an obstetrician and gynecologist, and you write this book. When you wrote the book about your experiences, did you know you were writing a human rights book?
I suppose, yes. I mean, I think that I sort of touch on it a few times in the book that sexual and reproductive health, maternal health, they are fundamental rights to all people in all situations. And one of my reasons for writing the book was to try and bring that to as wider readership as possible, to people who might not always consider that this is a right that should be extended to all people, and may not consider that this is a right that doesn't exist in specific situations such as humanitarian emergencies.
But it seems to me from reading the book and looking at it through a human rights lens, I mean, these women are some of the most unfortunate in the world. I mean, the appalling conditions in which women are giving birth in Sierra Leone or trying to give birth in Sierra Leone. Can you give us a little flavor of that? I mean, that is how you start the book.
Yeah, I mean, I think Sierra Leone is an unfortunate example of many countries, particularly in sub-Saharan Africa. And what you're seeing is the combination of how women and girls are perceived politically, economically, socially, culturally within their society. And what this comes down to is their lack of agency and sometimes their lack of ability to be able to access healthcare in a way that is timely and appropriate. And so, for example, if we were to take Sierra Leone, for example, you might be talking about especially vulnerable people. So a teenage girl who's not had access to education, who comes from a very poor family in a rural area, who gets pregnant, for example, as a way to bring income to the family or to get produce from the market, or even in a way to access her education. She may not have access to contraception, to being able to control that, and she may not have access to safe abortion care. And so by very virtue of becoming pregnant, she automatically enters this world where her life becomes at risk, because the efforts to end that pregnancy safely also become difficult. And we know that, that there is a woman or girl dying every 8 minutes from an unsafe abortion. So that already is a risk. But if this pregnancy were to continue and she were to have complications during that labor, whereas for many of us who are privileged enough to live in high-income countries, we can imagine a complication in labor being in a hospital, having access within minutes. In London, if I have a woman who has distress during labor, I know that that baby can be born within 5 minutes of that distress being picked up. Whereas for a girl or woman in Sierra Leone, you're talking days. And as I said, that's repeated in many countries, whether it's Ethiopia, Democratic Republic of Congo, Nigeria, Central African Republic, that they have the difficulty in knowing when to ask for help, being able to afford to pay to get to that help, finding the transport there, having a safe means to get there, whether that's safe transport or safe roads to travel down if there's an active conflict, and then actually receiving the healthcare that's safe and appropriate once they get there. So you're looking at a journey that is full of hazards. And to be frank, those hazards begin before she becomes pregnant.
So there are hazards all the way, but then one of the things I was interested in the book is there are sort of hazards for you as a doctor as well, and you describe ethical dilemmas when you're dealing with a woman. So you have a woman with preeclampsia, I think, and then there's also Ebola is already there. Can you explain a bit about those ethical dilemmas?
Yeah, I mean, I think with ethical dilemmas, there's two groups of ethical dilemma that you can sort of take from the book. There are the ethical dilemmas that exist in providing sexual, reproductive, and maternal health care in a resource-poor setting or a humanitarian emergency, where you simply don't have all the tools at your disposal to do what you know needs to be done. And where sometimes you're in a conflict between trying to do the right thing for the immediate, but also taking into account what might be the long-term consequences of those actions. So, for example, those 3 days that it took to reach the hospital, if you do a cesarean section, will be another 3 days next time. And then you've left this person with a much higher risk of complications, such as a rupture of that previous scar. In Ebola, which was quite a specific situation, the ethical dilemmas that we faced, particularly at the beginning of the epidemic, were the similarity in the manifestation of symptoms that you would see with a person presenting with Ebola, and the same that you would see with a woman or girl presenting with pregnancy complications. And that's because both are quite generic, non-specific symptoms. So you might, for example, have a woman or girl presenting with bleeding, with fever, exhaustion, vomiting, abdominal pain, with a stillbirth or miscarriage. And that would be our bread and butter for a maternity unit, particularly in a place where it takes a long time to reach that healthcare. So by the time you arrive, you've already got multiple medical happening at the same time. And the correct action in that moment would be to work in a time-sensitive manner. So it's critical to be fast and efficient and provide life-saving healthcare. The crux of the problem in an Ebola outbreak is that those same symptoms would also meet the case definition for Ebola, which is a viral hemorrhagic fever, a disease with a high risk of transmission through bodily fluids, which of course pregnancy and childbirth has a lot of, and also that your strategy would be the absolute opposite. You would want to be working very carefully, very thoughtfully, taking your time to make sure that yourself and your other healthcare worker colleagues are protected, and working towards non-invasive procedures as much as possible to reduce that risk of transmission, and getting a test and a diagnosis, which might take days, which means that, you know, if it's an obstetric emergency and you wait days, the likelihood is that this woman, girl, and probably the pregnancy will not survive. But if you decide to bring them into the maternity unit and quickly do a cesarean section and have her on the ward amongst many other women and children, and you're wrong, and you find that actually this is Ebola, not only is it very likely that she will have died within the first 24 to 48 hours, but the risks that you've put all of your colleagues and those other patients at will be immense.
And this actually happened, didn't it? Can you give us an example of that?
Yeah, I mean, this happened multiple times throughout the epidemic, and it's a cornerstone of why.
But give me an example of one woman. I'm trying to think of it from the point of view of one woman.
Sure. So I can explain the woman who I start the book with, actually, and this was a woman who came to us fully pregnant, so in the late stages of pregnancy, on the back of a motorbike, as these women would often arrive. So they would often arrive on a motorbike with one person in front, the driver, and one person behind, often a partner or relative, and with their arms strapped around the woman to keep her upright as they come down these really bumpy roads. And this journey could take hours and hours, even more than a day. And this woman had come to us with seizures, which in our context was very common for a condition called eclampsia. So one of the key causes of maternal death in the world. It's common in Sierra Leone, and there is a treatment. So it's also life-saving. We can treat and cure the woman, and also in most cases save the baby as well. And so this woman arrived with this history of seizures, unconscious, and she also had some bleeding from her mouth. Now, Ebola, of course, can cause bleeding from the mouth, but so can eclampsia. It can cause clotting disorders, and people often, when they have seizures, bite their tongue, bite their lips, and might fall flat on their face. So we were faced with a real dilemma here. You know, what do we do? Do we think this is Ebola, and do we isolate her? And at that time, it was taking about 3 days to get a result, 2 to 3 days. Or do we bring her in and treat her? And the only thing that really put the balance for us was where she came from. And that was that she came from a place quite far away where there was a known cluster of Ebola cases. And that was enough to push us towards, okay, let's isolate. And actually, once she was isolated, and isolation takes time. The PPE, and we're all very familiar with PPE following COVID, but the PPE that we use in Ebola is much heavier, much more time consuming. It's incredibly hot to wear. So once all that had been done and she'd been taken into isolation, we did try to start the treatment for eclampsia. However, she died almost within arrival. And so you can imagine it was an agonizing few days, with us all really going through these postmortems in our mind of, you know, what made us think it was one way or the other? Should we have actually taken her inside? But ultimately, it did test positive for Ebola, and the decision was right. But that doesn't take.
That is such a difficult ethical dilemma. I mean, you talked about the PPE in the book. Take us back to the moment when you realized that Ebola it's a huge thing. What was that like for you and your colleagues, both your local colleagues and your international colleagues?
So when I first arrived in Sierra Leone, we knew that Ebola was there. We knew that this was an outbreak of significant concern, but no one was panicking at that moment. There was some noises made mostly by MSF, Médecins Sans Frontières, who were saying, look, this is very different to other outbreaks. It's crossed international borders. It's got into urban areas. But there were other organizations such as World Health Organization and some of the governments of the countries affected who were still very much saying that this is under control and we expect this just to burn itself out. So when I first arrived, there wasn't that feeling of this is this big explosion that's going to surround us. That changed very quickly for me. It changed within the first couple of weeks. And that was because we started getting more and more of these patients arriving where we didn't know whether it was Ebola or not. And also because the trajectory of the epidemic was sweeping through the country, sort of from the east with the border with Guinea, sweeping towards us. And from the epidemiological data, we could see that we were having an influx of cases. And not only that, I think...
That must have been terrifying, Ben. Was that not terrifying?
It was at the beginning. It was very frightening at the beginning. The first few cases were very frightening. But I think like most things, you can normalize them. And, as time went on, it never became mundane. It never became something that we weren't respecting, but certainly that level of fear and panic dissipated, and it became much more about how can we react to this appropriately? How can we ensure that we're working with the communities and finding ways to ensure that they've got access to healthcare? I think there was sort of a psychological switch that flicked at some point for me.
Well, you made a very difficult decision, which was to close down that maternity ward.
Yes.
And everybody was against it, yet you made that decision.
Yes. So closing the obstetric referral centre is a decision which I think for myself and for all of my colleagues will stay with us forever. We were working in a country which we knew had this absolutely unacceptable level of complications, morbidity, mortality related to pregnancy. And the referral centre was an absolute lifeline to many women and girls. And we took a decision to temporarily close it. I think, when I reflect on that decision now, I like to think that if we were given the same situation with the knowledge and experience that we have, we would make very different decisions, and we would be able to find a way to provide healthcare in an Ebola epidemic or similar that will continue to maintain access to all the other health conditions that still exist and still need treatment as that's ongoing. But at that moment, in 2014, we were in a very unique situation where we had to make a decision on what was safest for us and our colleagues. And it had got to a point where it really felt that we were just waiting for an absolute disaster in terms of infection control, in terms of, if you're a Sierra Leonean healthcare worker, your chance of dying from Ebola was 32 times greater than a non-healthcare worker in Sierra Leone. And there was a huge responsibility in protecting our colleagues from that, but also thinking about what is the world after Ebola going to look like in a country where there was already such a lack of healthcare workers, such a lack of midwives, doctors, clinicians, that if we were to risk their lives during the Ebola epidemic by not having a facility that was able to protect them, then after Ebola, we were going to be leaving the population with an even worse healthcare system than they started with. But absolutely, it was a devastating time, I think, for all of us.
I'm very interested in the Sierra Leonean healthcare workers, because, as you say, they are really on the front line. They are in the greatest danger, and it seems to me that that is a human rights issue as well.
Absolutely. The protection. I mean, the book focuses on Ebola, but you can also look at more recent experiences that we've had. You can look at what happened during COVID, and the same challenges came up again. How do we ensure that healthcare workers are protected so that they can provide the healthcare that they go to work to do, that they have that passion to do, whilst also being safe in themselves, but also safe to go back to their own families, to their communities, not concerned that they themselves are going to become a vector in spreading something which is very harmful. And I think this is where healthcare, politics, economics come together. And, ultimately, these are political and economic decisions. How much do we want to invest in our healthcare system? How much do we value the lives of our community? And in this situation, pertinent to my book, the lives of women and girls. And how much do we value our healthcare workers, ensuring that they've got the means to provide that care, but also to do so safely? And it absolutely is a human rights issue. It's an occupational rights issue. But my fear is that we go through these cycles, we notice them, we highlight them, we wring our hands and say we're going to learn lessons from this, and then we don't, and we see it repeated again and again.
But from your point of view, it's also about love, isn't it? Because when you're in that kind of intense situation, the team you're with, the nurses and doctors you're working with and amongst, there's a love which binds you together, isn't there?
I think there's certainly a strong camaraderie. I think sometimes there's nothing that can bring a team closer together than when you're facing some sort of existential threat. You all come together. You might have many differences of opinions, and in all work environments, there are going to be people who get along and don't get along. But when you're facing a unique threat to yourselves, you can come together on deciding you need to find a way to do this in as safe a way as possible. But also because, and I think this is really the center of it, you want to make sure that you're still able to provide healthcare to the population that need it. And that was always the priority. And even in closing the maternity unit, as sort of ironic as it sounds, part of the decision to suspend the activities was also about thinking, how can we protect the population that we want to care for in both the immediate time, because we want to make sure they're coming to a place that is safe, that they're not going to be coming to what ultimately would become an amplification point of disease, but also in the longer term, to make sure that there will be a health centre and health workers to provide that healthcare for them once the crisis is over.
So there's a quote which I'm just going to find it in the book because it struck me so much. You wrote, because you volunteered to stay during the Ebola outbreak, and of course some people left, other healthcare workers. And you wrote, I was not staying because I was a doctor. I wanted to be present because I was a human. What did you mean by that?
So when I wrote that was in a place called Kailahun, which was at that time the epicenter of the Ebola epidemic. And the truth is that, at that moment, there was very little in medical expertise that was required for treating Ebola. There wasn't a vaccine. There wasn't a specific medication that we could give. It was really about supportive care. It was much more about nursing care, hygiene, and helping patients find their way through that journey and hoping that they would survive as best as we could support them. And so I didn't feel like I needed to be there from an aspect of clinical expertise, but from an aspect of witnessing what was happening in those mountains, in that border area, and having solidarity with my healthcare worker colleagues from all over the world, but especially from Sierra Leone and West Africa, and also having solidarity with those communities that were most affected, felt incredibly important to me. And if there was nothing else that I could offer at that moment, it was being able to record and bear witness to the immense suffering that was happening, and in part the result of global inadequacy in our response to it that was resulting in that suffering.
You're quite strong, aren't you, on this issue of global inadequacy? Tell me what was inadequate about, I mean, this answer could go on forever, but try and sum up for me what was inadequate about the response to Ebola.
So I think you could look at the Ebola response in different phases, because it did change, it evolved over time, and the response at the end was very different to what we were talking about at the beginning. But this time that we're talking about is that the climb up to the peak of the epidemic, and what I would consider to be the most distressing period of the epidemic. And what I found with the international response at that time was that there was a lot of interest in what was happening. There was a lot of coverage, and there was a lot of talking about we need to respond. But what people meant when they said that was to send donations or to provide documents. What was needed was for expertise to come to the field, to be there with us on the ground and helping logistically and clinically support a response that would bring the epidemic under control. And, I think that it's really important when we're talking about something like Ebola to understand that bringing the epidemic under control is not only about bringing Ebola under control, because it influences every single aspect of society. There's so much fear, and the way that society behaves changes incredibly. So there needs to be political support, there needs to be economic support, there needs to be real engagement with communities affected, listening to what they need, and then having international support to ensure that can be provided. And although that was recognized, I think, quite early on, it didn't happen until much later. And whether by coincidence or not, it happened once you started seeing more Western aid workers being infected. And it happened once there was transportation of the disease through air travel. And that's when you saw the real commitment to give full support to bringing the epidemic under control. But as I said, in that early time, it wasn't there.
I mean, you say in the book that the British response, which was partially a military response, was 7 months too late.
Yes, I mean, it's not me that says it, it's the data that says it. It's the publications by epidemiologists at LSHTM who say it, that, had they come...
HTM? What's SHTM?
Sorry, the London School of Hygiene and Tropical Medicine. So they published a paper showing that, had the response been earlier, the number of infections and deaths would have been half. And I think that, the British, I don't mean to, to undermine the British response, because the fact that there was a response from the UK, from France, from the US is incredible. And it was impactful and it was meaningful, but it could have come a lot earlier.
But I think this is an endemic problem, isn't it? Because we're looking at Tigray in Ethiopia now. I know that you have been there, and I have also been there in the past. And I'm seeing hunger. I'm seeing the deadly combination of drought and war, which potentially leads to the kind of famine that we saw in 83, 84, 85. And yet, at the moment, we don't have, thank God, those horrendous pictures of starving children. And yet we will, if if something isn't done soon. And it seems that we repeat this again and again. We're always late.
Yeah. I mean, I completely agree. And I think that's one of the messages that I hope comes through the book, is that we have not yet learned how to stop repeating the same mistakes again and again. I think sometimes we are not we politicians will say we have learned lessons. We saw this particularly, I think, during COVID in the UK, through the inquiry, that there's all these lessons that are going to be identified and learned. But then when it comes down to it, and we're faced with these emergencies, we often repeat them. And Tigray, I think, much like Sierra Leone, it also comes down to where it sits on the geopolitical agenda, and how important it is to the power makers of our time at that time. And now, as we are recording this, there's multiple emergencies around the world which are grabbing a lot of attention. Rightfully so. It's not, there's no competition. It shouldn't be a competition of who's got the greatest numbers, who's got the most pain. But we have the situation in Gaza, we have the situation in Sudan, we have the situation in Tigray. And well, you're the journalist.
I'm going to say, tell me about it. Tell me about it. I spent my whole life covering one emergency or story and feeling guilty about the ones I'm not covering. Whatever I do, I feel guilty about the other thing. Actually, do you ever feel that as a doctor, or are you more sort of, I was going to say, clinical, about understanding that there's only so much you can do?
I think in my clinical role, yes, very much so. It's one patient at a time. But in my role as an advisor for MSF, I do feel guilty. I think that as a humanitarian, I want to be in a position that I can reduce as much suffering in as many places as possible, through ensuring access to healthcare. But resources are limited, and also I, like everyone else, work according to the restrictions imposed upon me through those resources. But when we have, for example, Tigray. I was there last year working with teams, and we know that the impact of the conflict there has been absolutely devastating for sexual, reproductive, and maternal health. We know that in some areas, the chances of a pregnant woman or girl dying are 18 times higher now than they were before the conflict. And in most areas, it's at least 5 times higher. So the risks that this conflict and now the aftermath of the conflict are going to have are huge. And yet the response probably does not quite match the investment that's going to be needed to avert that.
Well, and related to that, another thing in your book, when you come back, and I think your book is very honest on a personal level about your own feelings, about what you've seen, what you've been through, what you were able to do, what you were not able to do. And you come back and you're pretty traumatized, if I may say, from what you've seen, which, I mean, I was traumatized from reading the book, so I understand that, and someone asks you what you feel and you say ashamed. Why did you say ashamed? The rest of us would look at you and say, but you did something and we did nothing, yet you felt ashamed.
I think it comes back to our earlier discussion. I felt like the needs were so huge, particularly the needs for sexual, reproductive, and maternal health. And I did not feel that we had met those needs in a way that we could have done. And I mean that we, as the international global community, not just MSF. And I felt on a personal level, I had been complicit in the closure of a maternity hospital, and I had tried to improve access to contraception at a time where women and girls were really coming to us desperate for ways to avoid pregnancy. And although we had some successes, none of them were as near as large as they needed to be, and as large as I would have wanted them to be. And so I was returning to Sierra Leone at that time, but returning very much with haunted by what I perceived to be my personal, but also collective failures for a population who I think deserved and could have had much, much better.
You say you were complicit in the closure of that maternity obstetrics hospital, and yet everybody came up to you and said, you know, that was the right decision. It was an impossible decision, but it was the right decision because so many healthcare workers might have died if you hadn't done it.
That is the beauty of hindsight. And you know that it is very powerful now and I'm still in contact, you know, with all these healthcare workers who are named in the book. I'm still in contact with them. They were all very much part of the writing process for me. And you know, even today we will reflect and look back on those times, and you know, we do mourn the loss of that health facility because of what it meant for the community and for the people who needed it. But yes, with hindsight, there is a recognition that we could not have continued doing what we were doing for much longer without there being an absolute disaster.
And tell me, before we close, because I think it does come down to individuals, doesn't it? Tell me about Morris.
So Morris was a clinical health officer. He was working in Calhoun Ebola Treatment Center. He, like many of the Sierra Leonean health workers, worked for months. They, you know, whereas I had the privilege, as with all international workers, I could come in and I could leave. If I got unwell, I could be evacuated. But Morris, like the other Sierra Leoneans, did not have any of those privileges. And yet he came to work every single day to provide healthcare to women, men, children with Ebola, and seeing every day death on a scale that none of us should ever be prepared to witness. And Morris, unfortunately, like so many healthcare workers in Sierra Leone and West Africa, himself was infected with Ebola, and he died in the same Ebola treatment center where he had spent the month before looking after and caring for others in the same situation. And I think that, you know, the loss of Morris and the loss of all of our colleagues at that time will have repercussion for generations, because they are a backbone to providing healthcare to the population, but also as a connection to the community and listening to the needs of communities in what is a very poor part of the world. I think that, you know, Morris as an individual, Morris and I, we would often work together in the Ebola Treatment Center. We would be what are called buddies, because you would never go in on your own. And very much you would look out for one another. You would check to see that you were keeping safe at all times. We don't know how Morris got infected. But I do think that, you know, had Morris been a doctor from the UK, like I am, the evolution of his illness and his journey with Ebola would have been incredibly different. And that is something which I think is important for us all to reflect on.
When you look back now, so you've written this amazing book, you've won the Moore Prize for Human Rights. What do you want the impact of that to be? If we should take anything away from this book and the fact that it's had this recognition, what do you want that to be?
I think probably more than one thing, but I'll start with one. The first thing that comes to mind is that through this book being awarded the Moore Prize, is that it will raise the profile for more people of the needs for women, girls, men, older people, young people in all settings, not just in Ebola outbreaks, but in all humanitarian and crisis settings, to have access to sexual, reproductive, and maternal health care. It impacts every single one of us in one way or another. And often we don't realize how much, we think about the pregnant women, and of course the book is very much on the pregnant women, but I could take the example of Ukraine, where we have much greater populations of older women who needed access to treatment for menopause, for organ prolapse, for urinary tract infections. There is the whole spectrum of the life cycle requires access to sexual, reproductive, and maternal health care, and it is a human right. And what I would really like to see is that the next time, Lindsey, someone is watching you on Channel 4 News presenting the next crisis, the next humanitarian disaster, that whether you say it or not, that they're asking themselves, but what about the pregnant women? What about the sexual reproductive health needs of the teenagers? What about the gay, lesbian, and transgender people in that society? What's happening for them? Because if we don't ask it, if we don't look for it, then our response is always going to be late, if it's there at all.
Dr. Benjamin Black, thank you very much indeed.
Thank you.